Good afternoon, good morning from wherever you're joining. Welcome to the National Hypertension Control Initiative, when COVID-19 and hypertension collide. It's a pleasure to have you here today. We have just a couple of housekeeping slides to share before we start with the main event. Just very quickly, we are running the accessibility features for closed captioning. You have the ability to manage these settings down at the bottom of your screen. Just look for that CC on the bottom of Zoom. You can either pop this out and have a running transcript on the side. You can change the size or even turn it off if you're finding it's in the way. With that, we'll move on to Q&A chat features. Please do use the Q&A button, the Zoom Q&A button on the bottom of the screen to submit any questions. We watch for and kind of curate all the questions out of this area, and it helps us make sure that we are keeping track of all the questions and don't lose them in chat. We've also got the feature going that you can upvote your favorite question. So if you see something there that you want to make sure bubbles to the top for Q&A time, please do make sure to upvote it. Chat is a great place to watch for resource links, share your thoughts, your reactions, responding, and just make sure your questions go into Q&A. With that, we're going to turn it over to Masa Massaquoi, Senior Public Health Program Manager for the NHCI team. Masa.
Thank you so much, John, and welcome everyone. My name is Masa Massaquoi. I am a Senior Public Health Program Manager for the AHA National Hypertension Control Initiative, also known as NHCI. And today, NHCI plans to give an update on the state of the pandemic. So if we go to the next slide, you'll find some of our objectives for today. So the first will be an update on the state of the pandemic. The next will be an update on heart disease and high blood pressure and the relationship to COVID-19. And then last, we'll wrap up with prevention strategies to reduce illness and death. Please note, after today's presentation, the slide deck with the attached resources will be sent out to your registration emails. And on the next slide, I would like to welcome AHA's and NHCI's very own Dr. Eduardo Sanchez to kick us off in our discussion regarding the state of the pandemic.
Good day, everybody. It's really heartening that so many people are on this webinar, registered for this webinar, and are interested in this topic. Admittedly, the topic of the day. For me personally, it's kind of interesting because I come with a background as a doc who started his career in a federally qualified health center in Austin, Texas. And I had the great pleasure to also serve as the local health officer at that same time. And then I served as the state's health officer. So this kind of communicable disease and non-communicable disease merging into where we are today with this webinar is really, really interesting to me. One of the things that I learned when I was commissioner and was testifying to legislative bodies was sometimes it made sense to start with the end because I might not get through a whole presentation with all the questions that might come my way. So I'm going to start with the end and then come back and we will end with the real end. But messages that I think are key. I'm sure you know these, but it's like everything. Hearing it again reinforces, and hearing it gives one the confidence to speak with others about these issues. So one, vaccines are the best protection against COVID-19, hands down, period. For the unvaccinated, let's do what we can to change their status. So if you've got patients who are unvaccinated, use your best motivational interviewing skills to move them from I don't think so to maybe I will to sign me up and get them vaccinated right then and there. Masks are protective. So even though risk is low, and I'm going to talk about that in a moment, if you've been vaccinated, if you're in a place where there's a lot of activity going on, and particularly in an indoor crowded place, a mask affords additional protection. And for those who are unvaccinated, masks are key. Flu season is coming. And I was reminded last week that the flu vaccine for seniors is available, and you can get vaccinated with both COVID and flu at the same time. Let's bring our patients back in, get them up to date on their vaccines. And again, with flu season on the horizon, and for some already a flu vaccine available, let's get patients in, let's get them flu vaccinated, COVID vaccinated, and get them back up to speed and up to par on their chronic conditions. Hypertension being one of the ones that I want to focus on today. And that includes both lifestyle kinds of issues. Are you eating healthfully? Are you able to be physically active? As well as, are you taking your medicines as prescribed and given your blood pressure control? Or maybe it's time to make an adjustment based on what we measured today and will confirm in the next few days. Next slide. So I want to start with just the reality, which is that in 2020, the number 3 cause of death in the United States was COVID-19. But I also want you to see that there are numbers there for heart disease and stroke and all these other things, and maybe excluding influenza pneumonia, every single other disease category, and one that's not on here, but it's the same for it, hypertension, the number of people who died as a result of those conditions was higher in 2020 than it was in 2019. And even adjusting for age, those numbers increased. The mortality rates were higher. So COVID had a direct effect on people by causing death in many, but it also had a secondary effect on people, causing higher death rates for a number, if not almost every other disease category. I'll talk a little bit about that in a second. Next slide. So I'm going to focus now on Delta variant because I did talk about 350,000 persons who died last year as a result of COVID. Let's go to the next slide where we've got some updated numbers. Delta variant is highly contagious. It is affecting the unvaccinated in a highly disproportionate way. The good news is that there is an intervention called the vaccine. We have not been social distancing up until just recently, as much as we had been in the height of the pandemic earlier. And I live in a state where people who ought to be using masks and definitely should be using masks given the circumstances in a crowded indoor space are not using masks. Next slide. So here's where we've got some numbers. We've exceeded 40 million total cases of COVID-19 in the United States. We will, based on these numbers, be on top of 651,000 deaths by the end of today. The cases per day are very high, but that number is decreasing, and that's good news. Now, that decrease is not happening everywhere the same way. And so states like Florida and Louisiana are seeing rates go down, and states like South Dakota, Ohio, Maine, and even South Carolina are seeing their case rates on the rise. So there's some variability in when the increases are happening and the peaks are reached and the decelerations or the decrease in cases begin to happen. In the United States, as of this morning, 54% of all Americans are fully vaccinated. That number is a slight increase from just a few days before. So Delta variant has gotten people's attention, and among people who are 65 or older, that rate is 82%. Now that's good news, but it also says that 18% are not fully vaccinated. There's some room for improvement there. And the Delta variant, there's a much lower mortality rate, and that probably is due to the age of persons who are being affected, the what we've learned about how to take care of people in the hospital who show up and need hospitalization. We're better at it now than we were before. And also this 82% rate among seniors has provided a lot of protection, at least for those 82%, and actually 92% have gotten at least one dose. That has reduced the burden and the burden of persons who are seniors who are ending up in hospitals, and has reduced the vulnerability in the segment of the population that was highly vulnerable and experiencing a very, very high mortality rate. Next slide. You will recall, and this has not really changed, that in the summer of 2020, the CDC provided a list of conditions where people were at increased risk of severe COVID-19 and those that might be at increased risk of COVID-19. I will remind you then that on the R at high risk of severe COVID-19 were a very distinct set of cardiovascular diseases and also persons who had obesity. I am focusing on this slide in particular because hypertension is called out as a condition that might increase the risk of severe COVID-19. Next slide. There's a few other things about COVID-19 that we learned early in the pandemic. Things have changed somewhat because of the vaccines that have been available and the vaccination rates that have been taken up. But we learned early on, and we observed early on, and throughout the first half, if you will, of this pandemic so far, that there was some disproportionality as it related to mortality rates due to COVID-19, and particularly African Americans and indigenous people were experiencing very, very high mortality rates as compared to other populations. All were high as compared to white persons in the United States. Next slide. Now, one of the really troubling, heart-wrenching things that has happened as a result of COVID-19 is that the progress that we had made over several decades to increase life expectancy has been reduced substantially. And I want you to focus on these three lines because they tell us a few things. One, the bottom line represents life expectancy for non-Hispanic Black people. And you can see that it goes from about 75 in 2019 to 72 in 2020. And that's a pretty dramatic drop. It's lower than what's depicted here for non-Hispanic white people, and for Hispanic people, it's lower at the beginning and at the end. For white people, you can see that mortality drops from 79 years to about 77 and a half, just to round around to the right place. And that's a drop, but it's not dramatic compared to the drop among Black people. And when you look at the drop for Hispanics, you can see that mortality goes from about 82 years to 79 years. And the so-called Hispanic paradox of this really high life expectancy, despite socio-demographic factors or socioeconomic factors that might predict otherwise, that has been, I wouldn't say completely erased, but it has been reduced substantially. Next slide. One other thing that happened is that over the course of the pandemic, we went from, people are not seeing their doctors. The good news, though, depicted here is that early on in the pandemic, as many as 40% of the US adults were delaying medical care due to COVID-19. That's problematic in people who have high blood pressure. That's problematic in people who have diabetes. The good news is that 40% has dropped to about 15% as of just a couple of months ago. And I suspect that number is staying down at about 15% despite the Delta variant, because we've all learned how to live better with COVID-19 as opposed to just not living because of COVID-19. Next slide. Here's some other sobering news, and I know that this has been reported once already, and that is that blood pressure control and the HRSA-funded health centers has gone down in 2020 compared to previous years. And you could see that from 2016 to 2019, there was a increase year to year, and then COVID. The COVID pandemic happened. The good news is we know we can be at 65%, but we also know we've got some work in front of us. Next slide. This is blood pressure also from this UDS report, the most recent one, by race, ethnicity. And I just want to highlight a couple of things. It's a busy slide and I didn't have time to sort of show you where I wanted you to look in your eyes. If you look at the bottom half, and that's for non-Hispanic Latino. If you look at African-American, that is Black/African-American blood pressure control levels, they are, I believe, the lowest number you'll see, 51.74%, whereas I would say the benchmark is about 58%. But what you can see is that there's variability, and we need to collectively figure out what might be contributing to that variability and reduce that disparity so that everyone is enjoying the highest level of blood pressure control possible. And while 61% is depicted on this particular slide, I would suggest to you that there's room for improvement that we ought to embrace as a challenge to ourselves. Next slide. This is just a little bit of a report that to me is the reminder of why we might want to make sure that our patients with any chronic condition, but this particular study would say people who are on statin drugs or antihypertensive drugs be on their medications and have achieved a level of blood pressure control and lipid management that we're satisfied with. And I would say this probably applies, intuitively, this applies to virtually any chronic condition. Let's get people back on the program with lifestyle and medication to achieve the physiological thresholds that we want to achieve with blood pressure control, with weight management, with lipid management, and with glucose management, particularly as it relates to cardiovascular disease risk factors. But this is a study whose findings come from the American Heart Association's COVID-19 CVD registry. Data from about 10,500 patients in 104 hospitals, and this is only through September of last year. 42% of those persons were on statin drugs. And what this study, it's an observational study. I want to be real clear. It's an observational study. 42% were on statins, 7% only on statins, 35% to constitute the 42 were on statins and medications for high blood pressure. And what was observed was that there was a reduced risk of death in persons with outpatient use of statins and their antihypertensive medications if those were being prescribed. There was additionally in the observation reduced risk of death with outpatient use of those drugs and a history of cardiovascular disease and or hypertension. So if you have those conditions, cardiovascular disease and or hypertension, and are taking your medications, and you get infected with COVID compared to somebody who's got a history of cardiovascular disease and hypertension and isn't taking their medications, the risk of death is higher. And it's just the reminder to us, I think we all would have believed that that's the case. This suggests that that is indeed the case, that having those cardiovascular risk factors and or cardiovascular disease under control is protective as it relates to what happens if you're infected with COVID-19. Next slide. So I think this is my slide to hand this off, although if not, someone can remind me. But during the pandemic, and someone interrupt me if they need to, during the pandemic, one of the things that was observed, and Dr. Salazar, who's going to be joining us, is an ER physician who might be able to speak to this very directly. We saw less people showing up in the emergency room for what would be a workup of a heart attack or stroke. Now, the sad news is that isn't because they weren't having heart attacks or strokes, because I think that what I showed you earlier in terms of cardiovascular disease deaths and stroke deaths in 2020 would suggest otherwise. It means that people were so afraid to go to the hospital that they weren't calling 911, and bad things were happening. Next slide.
And I think
So
we have the opportunity to run this 30-second video if you'd like to.
There you go, John. Thank you for interrupting me. So we did a campaign to encourage people, encourage them. If you have signs of a heart attack or stroke, call 911. It's the best thing you can do. Next slide, or run it.
Home is meant to be our safe place, but heart attacks and strokes don't stay home. Don't avoid the ER out of anxiety. Don't die of doubt. Don't stay silent, and don't stay home. If you have an emergency, call 911. When seconds count, the hospital is the safest place to be.
Wonderful. Thank you, Dr. Sanchez. Really appreciate your presentation today. Those numbers were incredible and quite up to date. I want to thank the entire team for pulling this together. And moving us forward, I would like to now introduce Dr. Gilberto Salazar, Associate Professor in Emergency Medicine at the University of Texas Southwestern Medical Center. Dr. Salazar has also worked with AHA and the NHCI team on our Community Conversation Spanish language webinar and has been a part of the AHA community education team. Please join me in welcoming Dr. Salazar.
Thank you so much, Masa. Thank you, Dr. Sanchez, and thank you to all of you for attending today. I wanted to reiterate a very important point that Dr. Sanchez made a second ago. During the pandemic, we had a lot of our patients who were concerned about coming to the hospital for rightful reasons. And I was the recipient of many patients in the months after who really wished they would have come a little bit earlier. So I saw a lot of patients who had strokes, heart attacks, and really went untreated. So kind of one of the first messages that I want to get across to our wonderful American Heart Association family and our attendees today is that we've taken a lot of precautions at the hospital to protect our patients. And even though we are constantly taking care of patients with COVID-19, we take the safety and infection control very seriously at the hospital. So please get help. Next slide, please. Wanted to discuss with you, and I'm coming to you today, not just as a physician, but I'm coming to you as well as a father, as a husband, as a son, and a member of my Latino community here. And I have been the recipient of many messages of encouragement, some of doubt. And I just wanted to kind of set the tone for you today. I am on the front lines of taking care of patients, not just with COVID-19, but a lot of medical conditions. And I want to make sure that our attendees really understand the severity of the problems that COVID-19 causes, particularly in unvaccinated patients with this latest surge. Our hospitals are absolutely overwhelmed. As of this morning, for example, the number of patients on ventilators who have COVID-19 is the highest that it's been since the beginning of the pandemic. So I really want to convey to all educators here and all members of the community that this is a real problem. And it is upon us right now to educate our communities on what we can do, what part we can do. This is not just a hospital problem. This is not just a nursing problem or a doctor problem. This is a true community problem. So our best available tool right now is vaccination. There is no doubt that vaccination conveys a very predictable and reliable antibody production that lasts for a very predictable amount of time. So even if you've had infection before, you may produce some antibodies, but that response can be pretty unreliable. And so vaccinations really allows us, they were developed in order to help control the amount of antibody production that we can mount in order to keep us protected for a long period of time. Right now, as of this presentation, 53%, and think about that, only really half of the adult population is vaccinated in the United States. Folks talk a lot about herd immunity, and what that is kind of the concept that the more of us that are protected, the less this virus has a chance to kind of roam around and infect others. And one of the scarier things that we're already seeing with this Delta variant is that this virus has had a chance to kind of roam around, infect others, mutate, and become smarter, more contagious, as Dr. Sanchez pointed out. So really at 53%, we're not anywhere near close to where we need to be in order to achieve true herd immunity. And vaccinations are proven to be the most effective, safest way to get to that herd immunity. Very happy to see that some of our more vulnerable population, those particularly who are 65 and older, are vaccinated. And the message that we as clinicians, as healthcare professionals have sent out is, please, let's protect especially our vulnerable populations. So I want to reiterate that a lot of work went into vaccine development. This technology has been around for many years. We just had never had the chance to deploy it. And now, thanks to a lot of wonderful folks who provided finances, to all the volunteers, to all the researchers, all the scientists, clinicians, a lot of work went in order to get this vaccine out and do it in a safe manner. So no corners were cut. And even though, yes, this was a record time in getting the vaccine, remember, a lot of the roadblocks that traditionally keep vaccines from being produced, manufactured, and distributed in a timely manner, those were not there anymore, thanks to a lot of people that really believed in this concept. Now, there was some hesitation as well, part of the community. Well, the Food and Drug Administration, the FDA, has not really approved it. So how can I know that it's effective? All along, we've known that they've been effective, that they've been safe. Folks, remember that over 5 billion with a B, vaccines have been given around the world. And we know that the safety profile is excellent. And it's so excellent now that the FDA has given its full approval for individuals as young as 16 years and older. And that is for Pfizer specifically. So folks, we have a lot of good data information from people like me who do this for a living. I take care of folks for a living. I research, I look at the science in order to take care of folks. And I'll tell you this, if this is not good enough for you, I don't know what is, but I put the vaccine through the test, and I did the research, and I was confident enough in it that I was vaccinated. I have my wife vaccinated and my 12-year-old daughter vaccinated. That's how much trust I have in the process. So let us find productive ways of addressing vaccination hesitancy in terms of a kind of a safety profile, and really mitigating a lot of the misinformation, a lot of disinformation that's being put out there, and making our patients very, very vulnerable. Next slide, please. We know from having been through this pandemic now over the almost 2 years, that's a really long time, that our bodies get absolutely destroyed by COVID-19 in many, many ways. And we know that COVID-19 attacks certain organs in the body, particularly the blood vessels in our body, causes this bad inflammation. It causes high coagulation, abnormally high coagulation levels that lead to things like heart attacks, to strokes, like clots in our lungs and other parts of the body. And so we've known for a while that COVID-19 puts you at risk for some of these diseases. And so how do we combat it? Well, we have prevention strategies. Oh, we got vaccination. Let's get masked up. Let's do the right thing in preventing from acquiring COVID-19. But what if you do acquire COVID-19? Well, in order for us to have the best shot at decreasing the severity and avoiding some of these really terrible problems like heart attacks, strokes, for example, our body has to be ready to tackle this challenge. So we've been very, very big from the very beginning that preventative medicine, particularly those with medical conditions like diabetes, high blood pressure, high cholesterol, and obesity, we know that these folks are at risk for developing severe COVID-19 when they acquire it. So we give them the best possible chance by taking care of some of these medical conditions, optimizing them and making them as healthy as we possibly can so that in case they acquire COVID-19, they have a good fighting chance. We know that statins, these medications for high cholesterol, really help us with mitigating a lot of the risks with COVID-19. So think about decreasing your cholesterol, what that does to individuals with high blood sugar, what that does to individuals who are obese. These medications really help us make sure that these individuals, these patients stay healthy, even if they contract COVID-19. We mentioned strokes and heart attacks. Remember that high blood pressure is one of the risk factors, one of the greatest risk factors, along with smoking, for developing heart attacks. And so it makes all the sense in the world that if you have uncontrolled high blood pressure, you are at a higher risk, much higher risk of getting superbly ill from COVID-19 than a patient who is really taking care of their blood pressure. So it's not just enough to take their medications. We have to be seeing our primary care clinicians, our professionals, often to make adjustments to the medication, educating them on exercise, on control of their diabetes, on weight control, and also along with vaccination and proper masking, proper public health, basic public health measures, we are going to keep our communities safe. Next slide, please. As we mentioned, vaccinations are our biggest weapon, and we cannot allow this community to keep going at a rate of only half of us being vaccinated. We already see, just from increased vaccinations here recently, from increased attention to masking despite mandates, that our hospitalizations are decreasing. Folks, there's no magic to this. We know that basic public health measures that have been around for many, many years, like masks and vaccinations, really do work. If you have any doubt on how to approach patients about this, just remember V+3W. Vaccine, first and foremost, biggest weapon. Wearing a mask, especially indoors. If you have to be indoors for any reason with anybody else around, please wear a mask. Masks reduce aerosolized particles spreading all over the place. Wash your hands plenty, as COVID-19 can survive on surfaces. And please watch your distance. We should be watching our distance as it is, and we all want to hug our family members and shake hands and really feel normal again. But until we get this pandemic under control, please, let's do V+3W. Thank you very much. Want to bring some attention to NCRN, the National COVID-19 Resiliency Network, which gives a lot of folks on this call today the resources that they need to approach patients or their families or even themselves. So please take a look at the attached on the link here for more information. And thank you so much again for having me.
Dr. Salazar, you and I are going to go to first name basis. Gilberto Eduardo. Just for the purposes of what's coming next, I think that David Pena is going to be doing some Q&A I do want to reiterate, I think things, what's great. Those who are astute would say, holy moly, Dr. Sanchez and Dr. Salazar said exactly the same thing. And I think we would say we intentionally said the same thing. These are such important messages. So just to repeat, get vaccinated or get informed about vaccination. And one place to go is getvaccineanswers.org. The American Heart Association is part of the COVID collaborative. Even though we are the Heart Association, we believe very, very strongly that all things that are protective of one's health and prevent disease are worth pursuing and doing. Number two, get on your prescribed medications if you're a patient, or let's get our patients on their prescribed medications. Let's make sure they're taking them and try to understand what barriers there may be and how we can overcome them. This message again to people, but the message to the provider community would be, let's connect with our patients and get them back into the fold. With regards to just knowing what's going on and making sure they're taking their medications, and then discuss with those patients the better way to manage their health. And if you're a patient, discuss with your care team the better ways to manage your own health. And I would put number 5, so I'm going to repeat it again. Flu season is upon us. One thing that happened last year is that flu season was not a thing last year, but it was not a thing because of 3 things: vaccine, masking, and we were washing our hands and watching our distance. Actually 4 things. It was the V and the 3 W's. And the Dr. Salazars of the world were not having to take care of or even see patients with flu because vaccine plus the other things was keeping flu out of the emergency rooms. And the degree to which we can continue to keep things out of emergency rooms that don't need to be there is the degree to which we can take care of the heart attacks and strokes with the full attention that those things require when they're being addressed. So I'll stop there. And David, I think you have some questions for us.
Absolutely. Yes. Thank you very much. I'll pose the first question from an attendee in the chat to Dr. Salazar. I have a patient who states she had COVID and now has those antibodies. She wants to know why she should get the vaccine, and her body's producing antibodies, and if she feels young and feels about some of that vaccine hesitancy as far as fertility and future children, things like that.
Absolutely. I feel so strongly about this that I put the answer in there in text as well. Here is kind of the bottom line when it comes to past immunity. Remember that every disease, every virus, every bacteria, every infection that we've ever had makes us produce antibodies. What we know about COVID-19, like many other diseases, is that when you're exposed to it, you do produce antibodies. The problem with this kind of natural immunity is that the amount of response, the amount of antibodies is very unpredictable, very unreliable. If you had a very small exposure in not a lot of severe disease, you're more than likely going to produce less of a brisk antibody, long-lasting response. Now, vaccines are engineered to give you a reliable, predictable, long-term protection. Okay, and we've studied this. I even did a test on myself after my vaccination, and you do develop pretty predictable antibody titers. So that's one way to approach patients, that even if you have the infection, you still need that predictable, reliable antibody response that lasts. Second, to this date, there is no clinical evidence. Remember that these mRNA-based vaccines do not have the power to change your DNA. It gets degraded. That mRNA, when it does its job and tricks our body into producing those little proteins so that we can create antibodies, that mRNA goes away very, very fast. It does not change your DNA. There's a lot of misinformation out there about infertility, and the same thing goes with every vaccine we put out there. There's the concern about infertility. That is just simply not the case, and there is no evidence to this day for that. As a matter of fact, the American College of Obstetrics and Gynecology, which is the most reputable body related to women's health and reproductive health, has given the go-ahead for vaccines, including for pregnant women. That is a superbly powerful statement by one of the most powerful institutions in the House of Medicine. So thank you for your answer.
Great. Thank you very much, Dr. Salazar. I'll follow up with another question concerning vaccination and individual status. One question from the audience was, what about the vaccine for children 12 years and older, as well as maybe talk about the prevalence of COVID now in that demographic?
I'll take that one as well, if that's okay with you, Eduardo.
Yeah, sorry, I was thinking about so I'm just going to say it. Dr. Salazar and I, in the NHCI team, are going to put this on in Spanish. Not a repeat, not a bad dubbing job, but live and in person in Español. So those of you who would prefer to hear this in Spanish, o conocen personas que preferían la información en español, por favor, comparte esta información and be on the lookout.
Thank you, Eduardo. Really looking forward to that webinar in Spanish. And to answer the question from Q&A, the vaccine is approved for kids 12 and older. The FDA approval is for 16, but we have emergency approval for kids as young as 12 years of age. And one of the biggest concerns in our community says, well, you know, my kiddo is going to school right now. Maybe 20% of kids are wearing masks, and there is no protection, no vaccine for them. What's up with that? Well, I'm going to give you just a piece of information that hopefully is going to make you feel a little bit better. Ongoing trials are happening this very moment for young children younger than 12. For the time being, until that vaccination time arrives, we continue to protect our children exactly like we've been doing. Masking, distancing, let's make sure they're washing their hands, and teaching them and reinforcing important basic public health measures is important. To give you a very good example about how basic public health measures really help, there's a virus called respiratory syncytial virus, RSV, and also flu. During the pandemic, normally during the winter months, our hospitals would be overwhelmed with these kiddos with these viruses. Well, during the pandemic, we did not see them at all. Why? They were not attending school, so they were not around each other. They were wearing their masks quite a bit, and they were taking really good care of themselves with basic public health measures. What happened the moment mask mandates were completely done away with and kids got back to school? Well, our numbers for RSV and influenza began to pop back up. So the key to taking care of our kiddos younger than 12 is basic public health measures, but there is help on the way. And I would really encourage you to get your kiddos vaccinated, because these trials are on the way, and the safety profile, I am very confident, is going to support the safety and efficacy for vaccinating kids.
Yeah, truth is, Gilberto, that it wouldn't be FDA approved even for emergency authorization use if it didn't meet those conditions that you just described. The very fact that they are approved means the science is solid, and the numbers of people that they watched are large enough that there's a very high degree of confidence. And I'm talking scientifically, scientific confidence that these are effective and safe medications when those approvals come. David.
Yes. Thank you very much.
You have a question for me, don't you?
Yeah, I have a question from you from the chat. Davita Watson asks, she wants to know what the difference between the original COVID-19 virus and the Delta variant, and why the Delta variant is more harmful to children.
Sure. So the difference, there is no difference between Delta variant and COVID-19. Delta variant is is a variant, is a form of COVID-19. So COVID-19 sort of entered the world in late 2019, and it had a particular form. And one of the things that viruses do, we know this, the influenza vaccine is a case in point. They mutate and sort of change. And if you remember Darwin and survival of the fittest, for viruses, survival means being able to withstand whatever the conditions outside of itself it is meeting with. So one thing is that if you are a virus, and they don't think, so I don't want you to think that this is a sentient being, but it's just a survival mechanism. One way to survive is to become more contagious. One way to survive is to be able to evade the antiviral, the vaccines. And in fact, in the bacterial world, what we have are strains of bacteria that are resistant to certain kinds of antibiotics. It's a similar kind of at least evolutionary mechanism to find a way to keep to stay infecting people and stay alive from the virus perspective. So the Delta variant is one of those variants that, and there's many. There's some that don't have names because there was a mutation, but it didn't make a difference. It didn't survive. But Delta is one that was more contagious, was being found more and more and more, was moving around not only in countries, but was moving across the globe. And here we are. So Delta variant is a more potent, a more contagious form of COVID-19. Now, the fact and so they are the same, and that's good, because the vaccine that was developed originally for the Alpha variant, the only one that was alive, actually continues working for the Delta variant. The fear is that the longer the virus can continue moving around and infecting people, and the higher the likelihood or possibility that a variant will emerge for which the vaccine that now is protecting me and Dr. Salazar and my mother and my mother-in-law won't work as well as it's working now. That's why there's a certain urgency around, let's get everyone vaccinated and let's do everything we can to kind of stop the movement of the vaccine. Because if you stop the movement of vaccine, you stop the likelihood that a variant could emerge in a very, very highly prevalent way, as Delta variant has. I do want to share something with you in answer to that question. So why are kids getting infected? Well, because the Delta variant is more contagious, and sometimes there's variation in how it exhibits its presence, and it is possible that some additional mutations are resulting in kids getting sicker than they might have been getting with the Alpha variant. And we know that happens with flu vaccine. So some years, with flu, some years there's influenza that comes along that is really, really harmful to seniors, not so harmful to children. And a few years later, a vaccine strain or strains will come along, more harmful to children, less harmful to seniors. So this is the kind of thing that happens in the ecosystem of viruses. Here's some good news though. September 7th, 2021, New York Times article. If you are vaccinated, a COVID infection is highly uncommon. It's highly uncommon. And what was thought of as being one of the reasons why the vaccine, the virus is so contagious, and that's this notion of higher viral load. That means that the Delta variant seems to cause a higher concentration of virus in your body than the Alpha variant, meaning that maybe you can spread it more easily. And when you do, there's more of it being spread. It turns out that if you're vaccinated, you're still protected, whether it's a high viral load or not. This was an interesting number. I'm just going to share it to make people feel better. The chances of an average vaccinated adult contracting COVID, if you are in a highly vaccinated community and are taking precaution in a highly vaccinated community, 1 in 5,000. That is, so 1 in 100 is 1%. 1 in 1,000 is 0.1%. So 1 in 5,000 is a half of 0.01%. It's a really low probability, but it doesn't mean that you shouldn't have some precautions like wearing a mask if you're in a really crowded place, in a place like Texas where there's a high prevalence right now and people aren't wearing masks. And one more thing to share, vaccine rates matter at a state level as well. Infection rates in the least vaccinated states are about 4 times higher than in the most vaccinated states. And so y'all are across the country, and there's some places where the Delta variant is having much less of an effect because the vaccine rates are high. And that's why people like Dr. Salazar, myself, are saying, if you have high blood pressure, get your blood pressure under control. But while you're doing that, go get your flu vaccine and go get your COVID vaccine. Is that a fair thing to say, Gilberto?
100%, Eduardo, 100%. We need to manage our risk factors. And one thing to point out that you said is having the vaccine already does convey good protection against getting the disease. But with this Delta variant, especially, you can still get COVID-19. And that's one of the biggest misconceptions. But I can guarantee you this, if you are vaccinated and you happen to get Delta variant, a form of COVID-19, you are way more likely to have less severe disease than somebody who is unvaccinated. And I am living proof of seeing patients day in and day out who are unvaccinated and they just do very poorly.
Yeah, so there's a question here about it's 1 in 5,000, and this is for persons who are vaccinated, even vaccinated and in a highly vaccinated community. So it's a combination of being vaccinated, being a high, but still, even if you're in a high activity and low vaccination rate, you're pretty well protected. And remember, COVID is, or more importantly, Delta variant is a form of COVID. They're not two different things. Delta variant is a form of COVID. It's a little bit like it's a jacket, but is it a red jacket or a blue jacket? It's a jacket. Okay. David, we probably have about time for maybe 1 or 2 more questions.
Yes. I'll pose this one to Dr. Salazar. One of our attendees asks, as a healthcare worker, how do you discuss the efficacy of the vaccine as it relates to long-term type of side effects and things like that?
Absolutely. As a healthcare worker, one of the things that you should be comfortable with, that I'm comfortable with, is a discussion about the risks and the benefits of things, of medications, of therapies, etc. There is no perfect therapy. Everything carries risk. So the conversation that I have with my patients is, listen, the risk of bad things happening to you if you take the vaccine, the risks are there, but they're small. They're very small compared to the benefits, like not dying or winding on a ventilator or having a stroke or a heart attack, financial, missed work, on and on and on. So it has to be a conversation about risk versus benefits, always saying to patients that the risk is there, but we have done the research and the science tells us that the chances of something bad happening as a result of the vaccine are very low. And we know with 100% confidence that bad COVID-19 can kill you.
Excellent, excellent. Thank you. The last question I'll end with for you, Dr. Sanchez. So as you touched on, evidence suggests that in some parts of the country, the 4th wave of cases is coming down. So my question, should we be hopeful that this trend will continue?
Yes, I do think we should be not just hopeful. I think we should anticipate that there will be the beginnings of things coming down, because I think there's a combination of things. Dr. Salazar mentioned vaccine rates are going up. People are being more careful. But the other thing is that if you look at the past 3 surges, you'll see that there's kind of about a 6 to 10 week period from start to kind of decline. And we are probably on the back end of those things. I'm not totally convinced that in Louisiana and Florida, vaccination rates went up terribly. But the virus itself sort of runs a little bit of its course. So it's a combination of things. I don't want to downplay at all the importance of vaccines and the importance of masking. And quite frankly, I think I want to underscore what Dr. Salazar was mentioning about what was going on here locally. The thing about this, about getting COVID right now, is that among those that are unvaccinated, they're ending up in the hospital. And while people are surviving, they are occupying intensive care unit beds for extended periods of time. And it makes it less possible for other things that need to be addressed in a hospital to get taken care of, whether that's a heart attack or a stroke. And, we believe, and I believe strongly, 911 is the number to call. But the other thing that I'd be lying if I suggested otherwise is that staff that's tired, staff that's worked hard, staff that doesn't see a break in terms of the action, because when you work in an emergency room, there may be periods where things are kind of going steady and strong, but there's also sometimes a little bit of downtime where you can get a breather. And I can't speak for you, Dr. Salazar, but I suspect that right now there are no breathers. It's 100 miles an hour the whole time you're on shift. That's very, very fatiguing and tiring. And your ability to think and be on your toes and do all the smart things that need to be done are a little bit challenged, if not a lot challenged, when those are your circumstances. So there's no doubt the hospital is the best place to be, but the best circumstance is when hospitals are not overwhelmed, when hospital staff has the capacity to think through all of the possibilities of what might be driving the particular thing that shows up. And so I will say that, yes, things seem to be coming down, but cases will come down about 2 to 3 weeks before hospitalizations come down, which will also be delayed by the overutilization of hospitals by another 2 to 3 to 4 weeks, because people who came in when were sick enough to be admitted are going to be there for an extended period of time. Dr. Salazar, did I misstate any of that in terms of the lag? Cases go down, then hospitalizations will go down because there's about a 2-week lag, and then people coming out of the hospital will go down because there's another 2 to 3 week lag.
That's exactly right.
Gentlemen, I think at this time, we'll go ahead and pass it over to Masa, wrap us up here at the end. Thank you for that answer, Eduardo.
Sorry for taking so long. It sure was fun talking with Dr. Salazar, and I hope that this was helpful to y'all who were on the webinar today.
Wonderful. Thank you, Dr. Sanchez and Dr. Salazar. This was a wonderful discussion. Great questions from the audience today. So let's jump right into our call to action as we wrap up today's webinar. So COVID infections are on a rise, and it's still vital to take important steps to protect our community. So as we said earlier today, and I'd just like to reiterate, get vaccinated, get information, use reliable sources, and then make the best decision for you and your family and your community. And please feel free to visit the resources on this slide for more information. We'll also drop that in the chat. On the last slide, as far as content, you'll see the NHCI continues to pursue addressing social determinants of health. We will be continuing our curriculum surrounding the MAP framework. So please note that the next Act Rapidly webinar will take place on September 23rd at 12 p.m. Central Standard Time. And to close us out with the next few slides, I just wanted to say thank you to the team. Many, many thanks, Dr. Salazar, Dr. Sanchez, David, and Celicia, Sonia, Nikisha, Drew, Pamela, John, Chris, Elise. We have a very big team to thank, and there's many, many more of us as well. But if you have any questions, please feel free to email us at nhci@heart.org. Also, please feel free to contact NHCI at support@hrsa.gov for support surrounding the NHCI Health Center Supplemental Award and/or its requirements as recorded in the Notice of Award. Thank you again, everyone. We welcome any questions and comments after the webinar, and we'll be sure to share the recording with those who have registered for the webinar.